Usually when you experience physical pain, the underlying mechanism makes a kind of logical sense to us.
Right. It's cause and effect.
Exactly. You stub your toe, the tissue gets damaged, and the toe throbs. Then you swallow an ibuprofen, it blocks that local inflammation, and, the pain fades. It's simple.
The biological wiring in those everyday scenarios is, well, it's very straightforward. A local structural problem just gets a local chemical solution.
But then you look at migraine,
Eh.
and suddenly your brain is treating a totally normal Tuesday afternoon like a full-blown neurological emergency.
Yeah, it's a complete system override.
You're hiding in a dark room.
Right.
The absolute slightest sound is agonizing, and that standard painkiller you took, it's essentially like trying to put out a roaring kitchen fire by just turning off the smoke detector.
Which obviously does absolutely nothing to stop the actual flames.
Right. If you or someone you know has ever experienced a true migraine, you know exactly the kind of systemic hijacking we are talking about here. We aren't looking at just a bad headache. We are looking at one of the leading causes of disability worldwide.
It really is a profound, cascading failure of your sensory processing systems. Your nervous system is basically amplifying signals that should be ignored. It turns routine environmental inputs into debilitating pain.
So today on our deep dive, we are pulling from decades of pharmacological history, medical research, and the latest clinical guidelines to figure out how you actually stop a migraine in its tracks.
The pharmacological rescue mission.
Exactly. We're focusing on a class of drugs known as triptans. Our mission today is to understand the first principles biology of how these drugs work, the specific people who should absolutely never take them, and the surprisingly dark origins of how they were engineered in the first place.
And honestly, that origin story is genuinely staggering. Because to grasp the elegant precision of how triptans work in your body today, we have to look at the medieval nightmare they actually evolved from.
Right, I was looking at the historical notes in our sources for this, and it is just wild.
Oh, it really is.
Because starting back in the 1920s and 40s, doctors were treating migraines with ergotamine. And ergotamine is derived from a fungus called Claviceps purpurea, which is the exact same fungal contaminant of rye bread that caused those historical outbreaks of St. Anthony's fire.
A horrifying medieval syndrome. I mean, peasants would consume this contaminated rye and just suffer severe convulsions, hallucinations, and literal gangrene.
Gangrene from a headache medicine.
Right. And the gangrene occurred because ergot alkaloids are what pharmacologists classify as dirty drugs. They do not have a single precise target.
They just flood the system and hit whatever receptors they happen to bump into.
Exactly. They bind indiscriminately to serotonin receptors, dopamine receptors, adrenergic receptors all at once.
So for a migraine sufferer back in the mid-20th century, ergotamine did provide some relief, right?
It did, because one of its many effects is powerful vasoconstriction. It aggressively tightens cranial blood vessels.
But the collateral damage of hitting all those other receptors was just immense.
Right. Patients suffered severe nausea, and the blood vessels in their extremities could spasm so violently that it cut off blood flow, which echoes that medieval gangrene. It was the definition of a blunt medical instrument.
So if ergotamine was essentially a shotgun, just blasting all of your brain's receptor systems and, hoping a few pellets hit the right target, the eventual goal was to build a sniper rifle.
That's a perfect analogy. And Patrick Humphrey, a pharmacologist working at Glaxo in the UK during the 1980s, is the one who set out to build that sniper rifle.
He looked at the chaos of ergotamine and made a really crucial observation.
He did. He realized that the specific therapeutic benefit, the reason the migraine actually subsided, seemed fundamentally tied to the drug's ability to constrict those dilated cranial blood vessels.
So he theorized there was a hidden mechanism there, a specific undiscovered serotonin receptor subtype located strictly on those blood vessels.
Right. He termed it a 5-HT1-like receptor. And his hypothesis was totally radical for the time. He thought if you could design a synthetic compound to selectively bind to only that specific receptor, you could isolate the migraine relief.
And entirely bypass all that medieval toxicity.
Exactly.
But the craziest part of the Glaxo story, at least from the sources, is that they didn't even have a full map of the human genome yet.
Oh, not even close.
They were synthesizing and screening compounds to target this theoretical receptor before scientists had even fully cloned or confirmed the receptor's underlying biological structure.
It really stands as one of the cleanest, most celebrated examples of rational drug design in the history of pharmacology. I mean, researchers didn't just stumble upon this molecule by accidentally leaving a petri dish open to mold.
Right, they didn't just get lucky.
No, they built a custom key for a lock they hadn't even fully seen yet. And that targeted engineering led to the creation of GR43175, which is widely known today as sumatriptan.
The very first triptan. It hit the market in 1991 as an injection, and it just completely changed the landscape for patients.
It was revolutionary.
The New England Journal of Medicine published these controlled trials showing a majority of patients getting significant relief within an hour. For a condition that had no fast-acting specific remedy, it was basically a medical miracle.
The clinical success was undeniable, but the scientific justification for why it worked was entirely rooted in the consensus of the 1980s, which was the vascular theory of migraines.
Right, the plumbing problem theory.
Exactly. This was the idea that a migraine was essentially a plumbing issue. The throbbing, agonizing pain was thought to be the direct result of blood vessels in the brain painfully dilating and stretching.
Therefore, sumatriptan was engineered specifically to bind to 5-HT1B receptors located on the smooth muscle lining those blood vessels, just forcing them to squeeze shut.
Plumber tightens the pipe, the pressure drops, the pain resolves. The narrative was perfectly neat.
But science rarely stays that neat.
Yeah. No, it doesn't. As neurological imaging and molecular biology really advanced through the 90s and 2000s, a totally new paradigm emerged, the trigeminal theory.
The field basically realized the blood vessel wasn't the main antagonist anymore.
Right. The true culprit was the trigeminal nerve,
Which is the major pain signaling highway that branches across the face and the protective layers of the brain, the meninges, right?
Exactly. Under this modern theory, the trigeminal nerve becomes hypersensitized. It begins indiscriminately dumping vasoactive neuropeptides into the surrounding tissue.
The most infamous of these being CGRP, along with substance P and neurokinin A.
You got it. And that chemical flood triggers what we call neurogenic inflammation. That localized inflammation is actually what causes the blood vessels to dilate.
Oh, so the dilation is a symptom, not the root cause.
Precisely. And then those dilated vessels physically irritate the already sensitive nerve, which creates this horrible, self-sustaining feedback loop of throbbing pain, photophobia, and nausea.
Wait, let me just process the timeline here for a second. If the new theory proves that quieting the nerve and stopping that initial chemical dump is the main event, does that mean the vasoconstriction they originally designed sumatriptan for is basically just a side effect?
That is a fascinating question.
Like, did Glaxo invent the right drug for the completely wrong reason?
Well, that specific question sits at the center of a major active debate in neurology right now.
Really?
Yeah. The most accurate answer we have today is that triptans are essentially a biological triple threat. They operate on 3 distinct levels simultaneously.
Okay, break down that three-pronged attack for us.
Sure. So first, they execute their original design. They bind to the 5-HT1B receptor on the blood vessels, causing them to constrict. That's the plumbing fix.
Right, the 80s theory.
Second, and this is where the modern theory comes in, they bind to 5-HT1D and 1F receptors located directly on the terminals of the trigeminal nerve.
Acting as a biological brake.
Exactly. They physically halt the release of CGRP and those other inflammatory neuropeptides.
So they stop the chemical flood right at the source.
And it gets better. Furthermore, they cross into the brainstem itself. They travel down to a relay station called the trigeminal nucleus caudalis and actively dampen the pain signals there.
Before they can even be transmitted up to the cortex where you would consciously feel them.
Yes.
That is incredible. So they aren't just squeezing a pipe. They are turning off the fire alarm at the source,
Yeah.
cutting the wire to the siren in the brainstem, and telling the brain's main processor to ignore the noise all at the exact same time.
Which perfectly explains why triptans are classified strictly as abortive medications. They are deployed to interrupt an inflammatory cascade that is already in progress.
They are not preventative daily vitamins.
Definitely not.
And I think this highlights a massive, incredibly common misconception. A lot of people hear the term migraine medicine, and they assume it is just super strong ibuprofen.
Oh, all the time.
They think they can just, borrow their friend's sumatriptan for a regular tension headache or a sprained ankle.
Which is a completely useless and potentially dangerous endeavor. Triptans possess absolutely zero direct analgesic or anti-inflammatory properties for generalized pain. Zero. If you take a triptan for a tension headache, a sinus infection, or a stubbed toe, the drug will circulate in your system and accomplish absolutely nothing. Its only function is shutting down that highly specific trigeminal cascade.
And because of that highly specific function, particularly that 1B vasoconstriction, the pipe squeezing action, you are entering a serious danger zone if you have specific pre-existing medical conditions.
The cardiovascular implications cannot be overstated. Because triptans force blood vessels to constrict, they are strictly contraindicated for anyone with a history of ischemic cardiovascular disease.
So if a patient has diseased, narrowed arteries from uncontrolled hypertension, previous heart attacks, or a history of stroke.
Then introducing a systemic vasoconstrictor can critically restrict blood flow to the heart or brain. It could potentially trigger a fatal ischemic event.
Wow. And even for perfectly healthy people, the sources detail something called triptan sensations, which honestly, if you don't know the pharmacology we just discussed, experiencing this would be terrifying.
It really would. Roughly 1 in 10 patients will experience these sensations shortly after dosing. Within minutes, they might feel a sudden, intense tightness in their chest, a wave of flushing, or a deep tingling sensation wrapping around their neck and jaw.
I mean, those are the exact textbook symptoms of a heart attack.
Clinically, based on a verbal description alone, it is completely indistinguishable from angina.
But it's not actually a heart attack.
No, in a healthy individual with clean arteries, this is widely considered a benign, self-limiting side effect of that mild 1B vasoconstriction. The vessels squeeze slightly, the sensation peaks, and then it passes harmlessly.
However, it vividly underscores why prescribers must rigorously screen patients for underlying cardiovascular risk factors before just handing over a prescription. So, let's assume you are a healthy candidate, right? You have a fresh prescription. The actual real-world application of this drug is still notoriously tricky, mostly because timing is everything.
Timing is the hardest part for new patients to master.
You can't just casually take the pill whenever it is convenient. Let's look at the aura phase, for example. Many migraine sufferers experience these intense visual disturbances, like jagged flashing lights or blind spots, right before the pain hits.
Right, the classic aura.
The logical instinct would be to take the triptan the exact second you see the aura, to beat the pain to the punch.
It seems logical, but counterintuitively, taking a triptan during the aura phase is generally ineffective.
Why is that?
Because the underlying neurology of a visual aura is driven by a totally different phenomenon called cortical spreading depression.
Cortical spreading depression.
Yeah, imagine a slow-moving wave of electrical silence sweeping across the surface of the brain. Because this is an electrical depolarization event and not primarily driven by the vascular or neuropeptide mechanisms that triptans target, the drug just finds no purchase.
It has nothing to bind to that will stop the wave.
Exactly. The ideal window is to dose at the very first sign of the actual headache phase.
But that window to act is incredibly narrow. The clinical guidelines in our sources place a huge emphasis on avoiding something called central sensitization.
Yes. If you wait several hours into a severe migraine attack, the constant barrage of pain signals fundamentally alters how the brain processes sensory input.
It rewires the board on the fly.
The pain pathways become entrenched, and this leads to something called cutaneous allodynia.
Allodynia.
Yeah.
So we are talking about a state where normal, non-painful tactile stimuli are suddenly processed by the brain as agonizing pain.
Exactly. A light breeze on the skin, resting your head on a soft pillow, or honestly just brushing your hair feels like touching a hot stove.
That sounds miserable.
It is. And once a patient reaches that state of allodynia, central sensitization has locked in. At that point, the triptan is far less likely to be effective because the central nervous system has already been fully hijacked.
You essentially missed the critical window to shut off the peripheral cascade.
You did.
To make matters even more complicated, you might swallow the pill perfectly on time, right at the onset of pain, but your body actively prevents the drug from working due to a biological roadblock called gastric stasis.
Right, because a migraine is a systemic event. It doesn't just affect the head, it physically paralyzes the digestive tract.
Gastric motility just grinds to a halt.
Completely. So if you swallow a traditional oral tablet during an attack, it might just sit in the hostile environment of that unmoving stomach for hours.
Just completely unabsorbed.
Unabsorbed and useless. This physical hurdle is why having alternative delivery methods, like subcutaneous injections or nasal sprays that bypass the digestive system entirely, is absolutely vital for patients.
Especially for those who are incapacitated by severe nausea.
Exactly. You need a workaround.
That physical hurdle of digestion actually perfectly illustrates a much wider problem with this entire drug class. Biological variability. Getting the drug into the stomach is just the first barrier.
Right. Getting it to the specific receptors in the brain is a whole different puzzle.
Which brings up the phenomenon of triptan hopping. Today, there are 7 FDA-approved triptans in the U.S., right? Like sumatriptan, rizatriptan, elatriptan, and so on.
Yes, 7 different options.
And they all rely on the exact same core mechanism we just discussed. Yet, a patient might take sumatriptan and get absolutely zero relief, but then switch to rizatriptan and be perfectly fine. Mechanically, why does that even happen?
It comes down to pharmacokinetics, specifically lipid solubility.
Okay, solubility.
Yeah, think of the blood-brain barrier as an incredibly strict biological bouncer at the door of your central nervous system. Some triptans, like elatriptan, are highly lipid-soluble.
So they slip right past the bouncer.
They do. They slip past, enter the brain rapidly, act quickly, but they also often fade faster. Other triptans are more water-soluble, meaning they get held up at the door, taking much longer to kick in, but sometimes they provide steadier, longer-lasting relief.
So because every patient's metabolism and neurological architecture is slightly different, your friend's fast-acting miracle pill might get rejected by your specific biological bouncer.
Exactly. Clinical trial and air hopping through 2 or 3 options is really the standard of care to find that perfect metabolic match.
And one of those specific options has a fascinating superpower. I was looking at the pharmacokinetic charts in our notes for frovatriptan.
Frovatriptan is a very unique case.
Yeah, because sumatriptan has a relatively short half-life of about 2 hours. But frovatriptan has a massive half-life of 26 hours.
It's a dramatically different pharmacokinetic profile.
So if you wake up with a sudden thunderclap migraine and need fast relief, frovatriptan is entirely the wrong tool. It is way too slow.
Much too slow for an acute attack.
But neurologists use it for a very specific, predictable type of attack instead.
Yes, menstrual migraines.
How does that work?
Well, these attacks are triggered by the predictable drop in estrogen right before the menstrual cycle begins. And they are notoriously stubborn, often lasting for several consecutive days.
So because frovatriptan stays active in the bloodstream for over a full day, it is utilized as a mini prophylaxis.
Right. Instead of waiting for the pain to start and just chasing it, a patient takes the long-acting pill just before their vulnerable hormonal window begins.
Providing a steady, multi-day chemical shield.
That's a great way to describe it. It's a brilliant exploitation of the drug's metabolic properties.
But navigating the pharmacology of triptans also means navigating some complex regulatory friction. Let's look at the major FDA black box warning issued back in 2006.
Oh, this is a highly controversial chapter in medical regulation.
Yeah, the FDA issued a severe highest-level warning against combining any triptan with SSRI or SNRI antidepressants.
The theoretical fear there was serotonin syndrome. It's a rare but potentially lethal condition of serotonin toxicity caused by overloading the system with multiple drugs that influence serotonin pathways.
And since you have 2 distinct classes of medication operating on the serotonin system, on paper, the FDA's caution seems entirely logical.
On paper, sure, but headache specialists pushed back aggressively against this mandate.
Why did they push back?
The clinical community argued that the FDA's decision was heavily reliant on spontaneous, unverified adverse event reports from the FAERS database rather than rigorous, controlled clinical data.
So it's based on anecdotes, essentially.
Sort of. And when researchers finally conducted a major systematic review in 2010, they found that the actual statistical risk was astronomically low.
Wow.
Furthermore, when they reviewed the FDA's own cited cases of alleged serotonin toxicity, the vast majority did not even meet the formal Hunter toxicity criteria required to actually diagnose serotonin syndrome.
Which puts the prescribing doctor in an agonizing bind. Migraines and psychiatric conditions like depression or severe anxiety are massively common comorbidities.
They frequently present together.
So you have a patient sitting in your office suffering from both. And as a doctor, you are caught between a terrifying FDA black box warning on the label and the broader clinical consensus that co-prescribing these life-changing medications is generally safe.
And often medically necessary. It perfectly illustrates the friction that occurs when regulatory action outpaces high-quality clinical evidence. It forces frontline prescribers to meticulously document informed consent and just navigate the gray areas of patient care entirely on their own.
And even if you find the perfect triptan and you have no conflicting antidepressants, there is a cruel biological trap lurking for the patient. Medication overuse headache, or MOH.
Yes, MOH is a huge issue.
Imagine you finally find this incredible pill that cures your agonizing migraines. You want to stay functional at your job, be present for your family, so you keep taking the pill every time you feel a twinge of pain, only to eventually discover that the miracle pill is now the very thing causing your daily agony.
Medication overuse headache is perhaps the most critical counseling point in all of headache medicine. If a patient takes the triptan or really any acute abortive medication too frequently, the central nervous system physically adapts to the constant presence of the drug.
It gets used to it.
Right. The brain essentially downregulates its own natural pain modulation systems, which causes the baseline threshold for pain to just plummet.
What is the clinical threshold for too frequently? When does this happen?
The general neurological guideline is 10 or more days per month.
10 days?
Yeah, exceeding that limit forces the drug to paradoxically generate headaches. It can violently transform an episodic migraine condition where you get maybe a few attacks a month into a chronic daily headache pattern.
It's like a rescue swimmer pulling you out of the freezing ocean. But if you panic and hold on to them too tightly, too often, they eventually start pulling you under the water with them.
That is exactly what happens. And the only medical intervention to break that devastating cycle is a medically supervised withdrawal period.
Which sounds awful.
It is. The patient must abruptly stop taking the offending triptan entirely, enduring weeks of intense rebound pain before their baseline threshold finally resets.
So those significant flaws, the medication overuse trap, but primarily the cardiovascular dangers of that 1B vasoconstriction we talked about, they eventually forced the scientific community back to the drawing board.
They did, and the shifting understanding of that trigeminal-vascular theory drove the next massive leap in drug development.
Because they realized the nerve-calming action of the 1D and 1F receptors was the true therapeutic engine, right?
Exactly. So researchers asked a critical question. Can we isolate the neurological benefits of the triptan but delete the vascular side effects completely?
One to the Daytons.
Yes, in 2019, the FDA approved lasmiditan, which is marketed as Rave-Out. It is deliberately classified as a DTAN to distinguish it from the older triptans.
What makes it different mechanically?
Lasmiditan is a highly selective 5-HT1F agonist. It binds specifically to the receptor on the trigeminal nerve that halts the inflammatory neuropeptide release, but it has zero affinity for the 5-HT1B receptor.
So it does not constrict blood vessels at all,
Not at all.
making it completely safe for the heart. Millions of patients with cardiovascular disease who had been barred from triptans for 30 years finally had a targeted rescue medication.
A massive clinical victory.
But beyond the clinical victory, it essentially proves the new neurological theory right. If you can successfully abort a migraine without constricting a single blood vessel, the 1980s vascular theory truly was a red herring all along.
Exactly. It provided the definitive clinical proof that the neuronal action, not the plumbing fix, was always the core mechanism.
So if lasmiditan solved the cardiovascular problem by focusing purely on the nerve, couldn't you logically go one step further?
What do you mean?
Well, if the ultimate goal of these drugs is to stop that toxic dump of CGRP, why are we messing around with serotonin receptors to act as a biological brake at all? Why not just block the CGRP?
That exact leap in logic birthed the newest class of migraine abortives, the Triptans.
The Triptans.
Yeah, these are advanced small molecule drugs that bypass the serotonin system entirely. They go straight to the end of the inflammatory cascade and physically block the CGRP receptors themselves.
They just plug the hole.
Exactly. They stop the neurogenic inflammation directly at the source, offering another highly effective, completely non-vasoconstricting option.
It is just an incredible evolution of pharmacology. Let's look at the massive picture we've painted today from our sources. We started with ergot, a toxic medieval fungus causing gangrene.
The shotgun approach.
Right. We moved to the 1980s, where Patrick Humphrey rationally designed sumatriptan, the targeted sniper rifle that isolates the benefit and restores millions of lives. Yet, over 3 decades of use, the scientific consensus flips entirely.
We realized we built a drug to squeeze blood vessels when we actually just needed to quiet down an angry cranial nerve.
And that specific realization births a whole new era of heart-safe Triptans and carpants.
It serves as a perfect case study in how medical science truly progresses. You know, it is rarely a clean, straight line.
Definitely not.
It is highly iterative. It requires challenging fundamental assumptions based on new evidence, and it relies on constantly refining our tools as our understanding of human physiology deepens.
But triptans remain a foundational treatment today, right?
Absolutely. They remain a highly effective first-line treatment, but their ultimate legacy in the history of medicine might just be the newer, safer pathways they illuminated.
Which leaves me with a final thought to chew on as we wrap up this deep dive. The strange story of triptans shows us that a drug can be life-changing, completely revolutionary, and wildly successful, even while the fundamental scientific consensus on why it works flips completely upside down.
It's a wild paradox.
It really makes you wonder, What other blockbuster medications are sitting in our bathroom cabinets right now, working their absolute magic to cure our ailments? For biological reasons we haven't actually figured out yet.
It's a humbling reminder of how much complexity is still left to map in the human body.
It really is. Thank you for joining us on this deep dive into the mechanics of migraines. Until next time, keep questioning what you know.